Health Committee, Room 8, 21st of January 2015.
Good afternoon. Thank you for attending, and particularly for attending at short notice. Very grateful to you. And I wonder whether we could start by introducing yourselves to those who are following the debate from outside the room. Perhaps starting with you, Mr. Smith.
I'm Sam Smith from Med Confidential.
I'm Nigel Mathers. I'm a GP from Sheffield. I'm Honorary Secretary of the Royal College of General Practitioners.
I'm Nicola Perrin, Head of Policy at the Wellcome Trust. I should also add for this purpose also on the Care.Data Advisory Group, as are we.
Yes.
I'm sorry, the acoustics in this room are rather poor, so you might need to slightly lean forward so that everyone can hear you properly. So again, thank you very much. I wonder, for those who are following this, who are perhaps not familiar with the in great detail with the background, could you start by giving us an overview of where you think we are now with Care.Data, what the key issues are that we need to tease out so that we make sure that we don't miss any of those this afternoon. And really, as you know, the focus for today is going to be on pathfinders. But if you could give us your overview of where we are now and the outstanding issues that need to be resolved, perhaps starting with Mr. Smith.
So to cover the 5 lowlights, which are mainly within the remit of NHS England, for those who opted out after the quote-unquote junk mail leaflets that went out a year ago, what do patients, NHS England and HSCIC think that people have been opted out of? What about opt-outs from hospital episode statistics, which have caused so much concern? Has that opt-out been implemented? And what will be different for the pathfinders? And what will happen beyond the pathfinders? And for the pathfinders, NHS England has now said it will send everybody a letter. And I think we've not seen any change of that now for several months. But 3 questions are still substantively unanswered, which we first asked the committee back in February. What will patients be told? Who will ensure that this is true? And how can those things change? And all the questions that we have arise from hiding the interactions between those 3 questions. What exactly will the opt-out do is an unanswered question which is key to a lot of those things. The first draft of the CAG regulations we've seen do not define promotion of health. And along with the HSCIC's new data sharing agreements which permit commercial reuse to carry on, it was nice to agree with Tim Kelsey that drafting the regulations for CAG in a panic after a 7-month pause was possibly unwise. From last summer, NHS England's commitment to publish the minutes from the Care.Data Programme Board, where all the Care.Data Pathfinder decisions are made, is entirely unmet. I understand that there is a hold-up somewhere in NHS England, but I don't know what that is. And finally, Dame Fiona's Care.Data report had a long list of unanswered questions, which we agree must be answered before any pathfinders proceed, and the 2014 annual report from the IRGOP provided case studies of what goes wrong when information governance and data sharing is not handled properly.
Thank you. Dr. Mathers, Professor Mathers, sorry.
Thank you very much. Our original concerns, which we raised last February about Care.Data, were concerned primarily with ensuring that the NHS was beyond reproach in terms of its use of patient data. And our work has been concerned with ensuring that that is indeed the case. So that's what underpins the concerns that we've had. The first concern that we had last February, which I think is being addressed within the Pathfinder, are that people need to know what they're opting out of. There needs to be information, and I know that there is a facility within the Pathfinder project to ensure that patients do receive, everyone over 15 3/4, I think, will receive information about whether or not they can opt out and what Care.Data is and so on. So that is one issue that is being properly addressed within the Pathfinder project. The other issue which we raised at the time was to to do with the hard-to-reach groups, the groups who may not be able to understand the communication in the form that it was delivered, and I know that that again is being addressed within the Pathfinders group. We also had concerns over whether the data, what it would be used for, and there's been a full and sort of comprehensive explanation of that, and I know that the legislation has been adjusted to address the use of the data, particularly for commercial purposes, and I know that the current position is that the data cannot be used for profit, but just to cover costs, and it doesn't go to insurance companies. That's what we understand. And our concerns, the two concerns really that remain, is that the whole thing has now become so complicated that I think it's, quite frankly, very difficult for only one person to understand all the bits of it, because there are a whole range of committees that have been formed. I've got 6 down on my list here, all of which have some form of scrutiny or oversight of the process, and our concern would be to ensure that all those groups work together, they have good communication, that they make sure there's no overlap between them, and that at some point in the future there is a report as to whether this sort of alphabet soup of organisations is actually functioning properly and efficiently. So that would be one. And the other thing is a plea to get this Pathfinder phase right, because I mean this is last chance saloon for care.data, and we shouldn't rush it. We need to do it properly. I do think that the way it's been set out, it is being done properly, but we really mustn't rush this. We must do it steadily in conjunction with patients and all other interested parties to make sure that GPs are on board and people whose records are going to be used are on board. So we must take that slowly and steadily, systematically, as we have done, but with the proviso, let's not make it any more complicated than it currently is. That's our position.
And Ms. Perrin?
I would agree with all of that. I think we've come a long, long way since where we were this time last year. At that point, we were calling for much clearer communications about the potential benefits, but also the risks and the safeguards that were in place. And we were also wanting much clearer governance arrangements and clarity over those safeguards. I think the work that's gone into the communication strategy has been very helpful and impressive over the last year. There's been an extremely good engagement and dialogue exercise, and the latest drafts of the communication for the Pathfinders practices, I think, is significant improvement on last year. We do still have some questions and outstanding concerns about the governance arrangements and the safeguards, particularly making sure that it is very clearly defined who can and cannot access the data for what purposes. And I think we're looking to see that in the confidentiality advisory group regulations that Sam mentioned. I think it'd be helpful to discuss those in more detail in this committee session. We also have some questions about the proposed mechanisms for access. The secure data facility that has been proposed for the Pathfinders may work fine for the Pathfinders. It's not scalable and proportionate for access beyond that, so really sort of taking into account what needs to be achieved in the longer term if there is to be a national rollout. And again, as Sam said, I think clarity over the opt-out is still important.
Thank you. I'm going to come to Andrew, and when we get to the end of the session, if you feel you haven't had a chance to make the points you want to make more fully, then do come back to that at the end. So, Andrew.
Thank you, Chairman, and I must apologise, I have Westminster Hall today, so I will be staying for the session. Just following the pause which you've already talked about in care.data, the Pathfinder areas were announced. Do you have any comment with regards to the choice of those Pathfinder areas, please?
I think the I think the Pathfinder areas were chosen systematically and rationally. We wanted Pathfinder areas that encompassed about 500 general practices. It's actually, I think, about 350 now. It's a whole range of areas. It's CCGs that volunteered to take part. There's 2 in the north and 2 in the south and the west. And it's a whole range of urban populations and rural populations, deprived populations and not so deprived populations. So it seems to me that it was a very rational choice to choose CCGs who were different from one another and CCGs that were volunteering to take part.
Any other comments from the panel?
As far as we understood it, that NHS England had said they would write to all CCGs asking them to take part. We know that that didn't happen, and they were picked via some mechanism of which we have no information.
Okay. And in terms of the Care.Data advisory group, are you satisfied that that they were engaged with properly and that the issues which you raised were adequately answered? Or do you have any outstanding concerns about the role of and the involvement of the advisory group?
The advisory group, of course, is not a decision-making group, and I found, personally representing the RCGP, we were listened to, our concerns were addressed very seriously, and appropriate written responses were produced to every issue that we did raise. So, and we've had a very large number of meetings. It's not been done very quickly and very superficially. It's been done with us fully informed, giving us all the information that we need to answer our queries.
I think the advisory group sees its role as a critical friend, and we've done both during the course of the last year. We have been critics where necessary, but we've also been friends where helpful. There were some initial questions around the communication, but I think we've resolved those, and I think we're working together effectively as a group, and I haven't felt that we're not being listened to.
I agree with those comments, and I think the questions we have are very much the last questions to be answered, but the process for which the group follows has been acceptable, and we have seen, for example, lots of communication materials, and for the last 3 meetings we have seen 3 different drafts of the Care Data opt-out materials, and they've been different. That the fact that is a good process when a decision is made of what the opt-out does, then I'm sure that it will be fine. But that is not a question for the advisory group. That is a question for the programme board and the programme itself.
I think the other thing to say is that there are a wide range of stakeholders on that group, and the fact that we're often all giving consistent messages, I hope is helpful to Care.Data in establishing its next steps.
Thank you.
Thank you. Barbara.
In its report to the Care Data Programme Board, the Independent Information Governance Oversight Panel sets out 27 questions, I'm sure you're familiar with them, that need to be satisfactorily answered by the board, and 7 conditions that need to be met. Looking through those questions myself, I mean, I'm thinking back to previous sessions which we'd have. I feel that the picture's somewhat clouded by what's gone before. So if you look at a question like, how do I know my data is safe? And the questions that go on from there. But we'd just like your input on are those the right questions, and what progress do you see being made towards them?
I think that they are... how do I know my data is safe is a question that is what we basically, if we're talking to patients, that's what patients basically ask some variant of. They want to know that their data being used by the NHS is safe. How that happens and whether or not, there was conversations, and then there's a secure data facility which is being scaled up and doing more things. The secure data facility is a very good idea, and this committee was instrumental in sort of pushing that idea forwards. The IRGOP has asked the question, and the answer is, well, what are you going to tell patients? And all of the stuff that's come before, I suspect some patients are watching this briefing, but most will not. So it's like, what are you going to tell them, and is that comprehensible, and will that actually make them feel safe? Or will you tell them something that generates another 10 questions, none of which are answered, none of which you have answers to? And I think that's the sort of that's the question that Dame Fiona is sort of looking to get an answer to. Is like, it's not just that question, but the answer cannot raise another 5.
I think the questions which she raises in this in this report, I think, are entirely appropriate. But I think that it's expanded the scope. This is beyond Care.Data and is establishing, I think, some more general principles that be applicable to other programmes of work. So I think the questions are entirely appropriate.
And from the GP point of view, while we're talking to you as a GP on the group, do you believe that GPs are able to answer those questions? Are they?
Not at this stage. No. Part of the Pathfinder work is to ensure that all GPs and practices have a toolkit, so they can, if they don't know something, they know where to look or who to ask. Because it is, as I say, it's become increasingly complex over the last year, and there does need to be some space and some resource available for GPs in order to make sure that patients are being informed correctly and appropriately, and particularly the implications of opt-out.
I think it's an extremely comprehensive set of questions. I wouldn't be able to identify anything that's missing from here. I think we're nearer to being able to answer some than others, but they are all very important.
Which are the questions that you think are furthest away? Because I suppose the point we'll get to today is when it might be appropriate to move with the Pathfinders, but how far away do any of you feel that is?
Well, as I was saying earlier, I think it's important to just take this step by step, but I would hope that by the summer we would know the answers to the majority of these questions. But we don't know until the Pathfinders have taken place, because it's been quite a slow start.
I think some of them, such as the one about the safeguards, will hopefully become clearer with the CAG regulations. The opt-out ones have to be clarified before the Pathfinders can go ahead. I think some of the ones about the data that's been excluded from the scope for the moment and expanding the scope in future doesn't necessarily need to be answered before the Pathfinders start, but there needs to be a clear process set out for how those will be answered going forward.
And I agree with those statements. And Tim at this committee, or Tim Kelsey, has previously said that there are no artificial timescales, and I would echo that comment. And I would also think that that's probably... So these questions are interrelated, and as we get closer to an answer, it is easier to answer more of them, which makes other questions easier. But I have no idea how long it will take NHS England. What does the opt-out do seems like a simple question, but they've been working on it since February, and we still don't have an answer.
Could I just ask you, you mentioned that there wasn't an open competition for CCGs to opt into being Pathfinders. Have you got any concerns about the Pathfinders that are there? Because I have to say, the question mark I've got is why 3 from one area, why the whole of Leeds? So it's just that you mentioned that.
One of the things that they are testing is communications. So CCG boundaries, especially in a city, are legacies of probably some previous local government arrangement or wards. And so one side of the street and not another. If you put a billboard up, what do you do? And it makes sense that they are some form of constrained area, and one of them needed to be a city, just so you can test a city. We know that the leaflet penetration in London was well under 50%. So yeah, to run a good Pathfinder, there needs to be a city, and as a result, most big cities have multiple CCGs, and I suspect Leeds is convenient given where NHS England is based.
Right. Do you have that?
Yeah.
Yes, David then, yes. I was sure you'd finished.
With great interest to what you're saying, what I want to ask you about is the scope of these Pathfinder trials. And do you think that the whole planned scope of the system, from collection to processing and the use of data, should be the basis of these Pathfinders, or rather should they be used to test the effectiveness of the technical process? In other words, is there a risk that we're asking too much of the Pathfinders and that we will find out not enough, or that the results will be confusing?
There are two aspects to that question. So can you get the data from the GP systems to HSCIC? Yes, there is an existing process which is being reused called the General Practice Extraction Service, so you can run the query. There are a few low-level mechanical questions like, will a GP approve it? But that is a solved problem that has been solved before. As to whether or not the data you get when you get it to the safe setting will be any use, I would refer you to the expert reference group as called for Care Data, where HSCIC convened a group of experts who do data analysis on the sort of topics They had a list of things that NHS England and others had said, we will use care data to do these things. And they would basically ask, for your expertise, here's the specification, here's what data you'll have, here's the question, will it answer it? And in some answers, it's like, yeah, we can actually do that because we'll have 4 months of data and that's enough for this question. And in other parts, it's like, no, because it's not in the specification. So there are a range of questions from a clear yes to a clear no, and that expert reference group did very good work and has produced a report which I hope the committee has been sent.
From the college's point of view, we have to look at it as a whole system rather than just individual bits of the care.data programme.
Okay.
So from our point of view, the comprehensive nature of the Pathfinders is going to enable us to answer most of the questions, I think, that are outlined in Dame Caldicott's report from the independent group before Christmas.
I think that's right. One of the most important things with the Pathfinders is to test the communications and the understanding, but you have to be testing that of the whole system, and I don't think it would work to cherry pick different bits. Having said that, from a research point of view, we recognise that the Pathfinders aren't going to be of enormous value. They're a limited data set. The secure data facility is fairly locked down for understandable reasons, and the data extraction will be limited as well. But from a research perspective, we want care.data to work, and if the way of getting it to work is to do it in a phased, staged process with Pathfinders first, then we understand that's the way it needs to happen.
Thank you. I'm finished.
Thank you, Rosie.
If the conditions the Independent Information Government Oversight Panel has laid down are met, do you think it's reasonable that the Pathfinder should go ahead on the basis that of patients opting out rather than opting in? Would that be reasonable?
My understanding is that legislation exists to say that opt-out is the way forward for care.data, and that's been our position, that we think that opt-out should be the appropriate approach for care.data, for all the reasons that have been outlined in previous discussions in terms of participation and utility of the data that's being extracted and used for the benefit of other NHS patients. So from the opt-out point of view, we think that this is an appropriate way to implement care.data.
That's a question with a number of possible answers. We have not, it is very much easier to run a good opt-out system than it is a good opt-in system. And it is incredibly easy to run a poor opt-in system. Because if you say somebody has consented to this, the plan for care data or whatever replaces care data is that this runs forever. What does that change as the program changes, new data, new treatments, all the things? Is that something that they should have opted into again? Where did the boundaries come from? And so we would look at any opt-in proposal that was offered. We haven't seen one, and we haven't really had the time to put one together. So the proposal that is there, which is set up by NHS England, is an opt-out proposal. So we look at, okay, how can we make the proposals that are on the table adequate, not, and there is no opt-in. We are aware that the British Medical Association has opt-in as a policy, and we very much look to see where that goes. And certainly, if there was an opt-in proposal on the table, we can look at it. As to opt-out, that provides, as part of a National Health Service, some level of onus to, for want of a better phrase, in inverted commas, do the right thing. And what does that mean? And one of the descriptions that has been used to us about care data is it was the most data they could sneak past with what they thought nobody noticed. And something else happened instead, but it's a case of what is good governance, what does that look like? Because there is then not quite a moral expectation, but there is a cultural and a ethical expectation on the various bodies involved that that's the level of engagement you've had with the public, and if they find out, what you get is last February in the hospital episode statistics.
And as I said, sorry, if I may just add to that, as I said earlier in the statement, the key principle for us is that the NHS and everyone who uses the data should be beyond reproach, and that people need to know what they're opting out of. And if those two conditions are met, and hopefully all this work is enabling those conditions to be met, then that's the underpinning of our support for opt-out.
Nothing would give me greater pleasure than to say, jolly good, this is where we are. But already in this short half hour, because for me this is a question of trust. And I was prepared to leave at the door when I came in today a fair amount of my cynicism. But in this half hour we've heard of promised minutes not being published, whether the pathfinders were volunteered or were actually chosen, whether people who've been promised to be written to have been written to or not, the promised regulations that were due in the autumn, they're still not to be seen. You're almost reasonable, say it's reasonable that we shall go for an opt-out instead of an opt-in. And I suppose my question to you is, from where we were before, what solid pieces of information, land as I would put it, is any different? What's really secure that you can tell me that you're at? What's different that you can tell me this is really going to be good and based on honest, transparent, open, people keeping their word? I haven't seen much of it around here, I've got to say.
I think that we've moved an awful long way since last February. A huge amount of time and energy has been expended. There has been, as Nicola was saying, a lot of time and energy has been spent in communications, and certainly the communications that I've seen, proposed communications for the opt-out, for the information leaflets, are honest, they're straightforward, they're understandable, and they're direct.
We haven't seen those yet. You have. I suppose I'm really going back to, but when people can say minutes were promised, they haven't arrived, regulation was promised, that's not here, it's delayed now until later in the year, you're probably going to actually start this without any regulation at all. It's ridiculous.
I don't think it can start without the regulation.
So you're saying that absolutely no extraction can take place until this has gone through this House and those regulations are laid?
That was our understanding.
I would be utterly shocked if there was a different understanding. I do not know. That it has always been there'll be CAG regulations, because there will be two things have changed since last February. There will be a promise of a letter to patients, and Dame Fiona Caldicott has oversight. And the question is, what does the letter say? And that will say some things. Is that going to be happy? If you send that to all of your constituents, is your mailbag going to explode as an MP? And so the question is, we don't know what that letter will say. And so it's a case of, well, we can't know. And it's a case of, if there's a good opt-out, if there's a good process, we can look at that. In terms of, we don't know what that letter will say, why do we think optimism and hope based on the principles that were the founding of the NHS and continued in that vein is probably the only thing I can actually cite, and the fact that there are people who can say, you are not meeting an obligation to the people of England, you can't do this.
The other things that I think have changed since last February, we've had the CARE Act, which has clarified the role of the HSCIC and has also given additional functions to the Confidentiality Advisory Group. They need to be set out in more detail in the regulations, but there's a starting point in legislation which is a step forward. There's the Information Governance Oversight Panel. There's also been a huge amount of work done by the Information Centre, understanding what's gone wrong in the past and learning lessons, and they're being much, much more transparent about requests for data and who data has been given to. There have been knock-on effects for the research community with serious backlogs and delays in getting research applications through, which is another set of issues, but it shows that they are taking their responsibilities much more seriously, I think.
Do you think those responsibilities can be discharged with a £500,000 fine, or should somebody go to prison for breaches?
I would be very supportive of much stronger, more meaningful sanctions for misuse, and I think there is a very important discussion to be had as to whether or not criminal sanctions is the best way forward. They would need to be very clearly defined to make it clear that it's for misuse with malicious intent, and you don't catch the sort of accidental re-identification, which is an honest mistake that is rectified very quickly. But I think there is an important discussion, and the sanctions need to be really meaningful to ensure there is trust in the system.
Would that apply to when the hospital episode information was on the internet? Should they have gone to prison for that?
I think it's the data user.
But that was out there and people could use it.
You have, at that point, there weren't clearly defined purposes for which data could and couldn't be used for. So you're introducing sanctions within a framework of what the data
I'm not
can be
asking
used
for it to be retrospective. I'm just suggesting if something of that order happened, should people...
I would hope they wouldn't be given access to the data going forward.
But they were in the past. And when you want to look at the future, you always look at history. And we're being asked to allow these virtually the same people to let rip once again. Okay.
I would hope that the scenarios, the secure data facility should prevent that scenario being possible, not that it shouldn't happen. And similarly, a number of steps. Now, those steps aren't fully available, but equally, a lot of this, we can make things impossible, not, it shouldn't happen. And if it is, it cannot happen because the data is only in the secure facility and leads in remote connections, not shipped on DVDs to anybody who wants it, then you can have a very different conversation. Should the people who've had breaches in the past be prevented from accessing it again? Yes. That goes to what CAG can take account of in its regulations, which goes to what the regulations say, and they are not yet published. And so can you say that there is nothing we can point to that says NHIS, which is one of the organisations that potentially caused a breach, or was one of the organisations where massive public concern was raised, and we'll come back to that in a second, should they have access to data again? And what are the rules that will be in place there? We don't know, because we don't know what CAG can say, and therefore they don't know what it can take into account. Certainly I think they would like to take it into account. That doesn't mean that legally they will be able to, because what happens when a large company who has breached for reasons where it is clearly the company at fault, because the example I use, and everyone wish I didn't, was a large university, a PhD student gets drunk, that shouldn't kill the research program, it should possibly just tell the PhD student not to drink quite so much. And if we can work that one out, well, that's a different problem. But there is a set of processes there that where somebody is to blame, where it is clear that should be the case. We don't know what the regulations will say, so we have no answer on that.
We're strongly supportive of tougher sanctions for any abuse of the data, and I think that the regulatory framework is a lot tougher than it was even a year ago.
I suppose I'm really saying it has to be criminal and prison, threat of prison, as opposed to money, which is absolutely no threat. If you're a multinational, $500,000, make it whatever you like, you'll pay it and do it again. But if the chief executive was going to jail, it might be slightly different.
Did you want to add anything to that, Tom? No. Thank you. I know, Barbara, you wanted to come in.
Just to come back to Sam Smith's point about CAG, I mean, in previous sessions I've raised the fact that CAG actually allowed a use of hospital data for what was effectively a price comparison website for private hospital procedures, which I think is an abuse, actually, of patient data. Why should details of anybody's operation go for that sort of use? And I think that goes to the point which we've had right from the start here, which is your point about reputation. If it is a PhD student that made a mistake because they had a bit too much to drink, that's one thing, because they have to get on and finish their course, otherwise they won't have a career. But two blokes, I don't know if it is two blokes with a kind of website that's comparing prices, that's the sort of thing that's the sort of application that can come and go. So do you, it's just a question of how we reassure ourselves that we're going to stop seeing that sort of usage, which is an abuse, I think. And I can't see a patient anywhere that would want their hospital data or their GP care data used in that way.
So that goes to two questions. One, HSCSC can release data for the purpose of promotion of health. What does that mean? Has it been written down at any point? The answer is not that we found it. My understanding is it will not be in the CAG regulations. But to your particular point, a company can create itself, cause a breach, shut itself down, and the same people start up a new company. Mm-hmm. And so whatever the regulations say, they must take account of a corporate history and also the individuals who caused a breach. When you make a request for data, you say who has access to the data, and equally their personal history, so that you can't basically shut your company down and get away with it. Your reputation follows you as well as the organisation. And equally, if an individual was not to blame but the organisation was to blame, they can go get another job doing the same thing at a different company without being tarnished, which means that if that reputation stays with an individual, they have more of an obligation to report wrongdoing, because it will not be held against them unless they have done something. Whereas if it would be held against both, if actions of a company were held against an individual who was not to blame on investigation and proper investigation, then there is an incentive there to keep your mouth shut.
But you've told us in your evidence that you've got concerns about the updated data access request forms because they don't require verification even that a customer is a legal entity and only ask for a company number. That seems the most cursory of checks on an organisation. Because the departure we've got into is away from the research community, whereas, students and people forging a career in research have got their future to think of, and their integrity is important to them, to the type of organisation that I talked about, throwing together a website app and trying to make some money out of it. So is that another concern that needs to be addressed?
It goes to that point where if in the research community you have a culture that the people in that community will probably stay there for their working lives, generally. And Nicola can speak to that point a lot better than I can. But it's a case of when you start letting companies have very different motivations to researchers, and so should be treated at least possibly slightly differently, but equally not completely.
Thank you. And just one final... Oh, sorry, you wanted to come in, Sarah.
Yeah, I think a lot will depend on getting the right definitions in the CAG regulations to be clear about what purposes are and aren't allowed, and to limiting purposes for solely commercial use. We have to recognise that pharma companies do some very valid and important research that does improve human health, and there may be some commercial gain as well, and we shouldn't be stopping that kind of purpose, but we need to prevent purposes that are solely for commercial use. And we are concerned that the CAG guidance needs to set that out more clearly. We recognise there can't be an exhaustive list of what is and isn't allowed, but I think it needs to go further than it went in the Care Act itself, and our understanding is that isn't the intention at the moment. I think there are...
Sorry, could you understand that isn't the intention, that it's not going to go?
That isn't the intention, yeah.
And that's a concern?
That's a concern. Our other concern about the regulations is how they fit with CAG's other roles, which were defined within the 2002 regulations, and particularly their role in relation to Section 251 and providing approval for use of identifiable information without consent, and being very clear that they still have that function. They've had a very transparent, clear process to administer it. They give robust challenge, but they also recognise why they have that function and do it very effectively. and there is a danger that the two regulations could end up conflicting with each other, and I think it needs to be very clear exactly the full remit of CAG.
Thank you. Can I ask, have you set out what you think the wording should be? Have you made it clear where you think it's lacking as a group?
No, we've had some discussions with the Department of Health. They've said that they will put more detail into the explanatory notes, but we haven't yet seen their latest draft, so until we've seen their revised version, we haven't provided wording.
I just wondered whether you've actually, as a group, made your own suggestions to what would satisfy you to see in those regulations, and whether, if you have done, or if you're about to, whether you'd send some to the committee as well.
We have suggested some things. We haven't gone into detail, but we can do if it would be helpful.
Thank you. And just one final point from me before I hand over to Valerie. I just wondered, it's not just about the culture within those who are going to receive the information. I just wondered whether you felt, as a group, that the culture within NHS England that led to, well, I guess there's a certain sloppiness, to be fair, about the way this first was set out. Do you feel there has been a recognition and a culture change within NHS England and the Health and Social Care Information Centre about how we should be going forward?
Within NHS England? No. Within the Health and Social Care Information Centre, they've had a new chief executive in April who was appointed before this blew up, and there have been a lot of changes to HSCIC. We are having ongoing discussions, and those discussions are productive, and we are being listened to, and steps are being taken. We can go into more detail.
In terms of the culture in NHS England, could you set out what you think the issues are that need to be resolved within the culture at NHS England?
I think that decisions get made and then are not reviewed in light of further conversations. So what will the opt-outs, taking the opt-out, which may not be the best example, what will it do? Well, there will be one opt-out, and all of the problems that come from what that decision has been made cannot be, or seemingly cannot be entered into. And I think it's, I wouldn't say neglect, but it's a lack of attention to detail.
Right.
My own view is that there has been a raising of consciousness in NHS England. They are much clearer about what they can or cannot do, and much more reticent about just going for it without ensuring adequate consultation and feedback. So my view would be slightly different.
So you feel there is a response, and
they've been, for NHS England, they've been amazingly responsive in my experience this time.
Thank you. And Ms. Parry?
I would agree that there's been a significant shift in the information centre's attitude to all this. I would also support Professor Mathers in his comments that the NHS, or NHS is too broad a phrase, the parts of the care.data team that we have had exposure to do get the issues now.
Thank you for that.
Thank you. And I suppose it was the screech of everyone else that caused NHS England to backtrack on certain things, and I suppose they feel there's not much accountability, which is why we're all sitting here today discussing this. But I just wanted to just pick up, firstly, one or two points on the Pathfinders, and then maybe ask a series of questions that have risen out of your evidence. Are you all satisfied? And you talked about NHS England not writing to everybody, but just a few CCGs for the Pathfinders. Are you satisfied that patients were involved and properly consulted on that? Is there any way of finding out or knowing?
And I don't think there was one answer. I know one of the Pathfinders, one of the CCG's patient groups wasn't consulted. Whether that's because there were multiple patient groups, you will have a range of answers. I don't think there is a single answer.
I think it was pragmatic. The decisions were made pragmatically rather than ideologically, that everyone had to be involved at every single stage of this, and it needed to be done. So my understanding is that CCGs were selected on the basis of them volunteering. Everyone was invited, but it was the volunteers who actually have taken part in the Pathfinders. And there has been some variation in the amount of patient involvement, but there has been some patient involvement in all of them, but it varies.
So were the patients written to say you're part of this Pathfinder
Well,
process?
that is part of the Pathfinder project
They
itself.
are.
They will be as part of the
Were
study.
they all written to?
Yes, yes, they will be.
Sorry, in the past, or they will be? Sorry, just to clarify
will
that point.
be.
They haven't been written to yet, but they will be.
Not yet.
Thank you. Sorry.
Did you?
I don't have anything to add.
Okay. And so you said they're volunteers. So did money change hands?
The fog is tidy.
Right. So we don't know whether they were given sort of like incentives to be a pathfinder.
That's a question for NHS England. I believe the sort of public statement was that costs will be covered. What that means, don't know. But I think the intent on the part of NHS England was that this would be cost neutral to the CCGs, but then you get into questions of accounting.
Yep. Okay. Can I just turn to some of the comments you made? Initially, Professor Mathers, you talked about, you said legislation was adjusted. Could you say which legislation that is?
Well, there was provisions put into the Care Act
Yep.
just before
Yep.
the Easter, I think it was just before Easter, wasn't it? When last year, when the business around no commercial use, not for commercial purposes. This is for the benefit of NHS patients and for the NHS.
Yes.
Although, as Nicola has pointed out, there in some circumstances the data may be available to pharma companies, but that is in the interests of direct patient care. I think that was the phrase that went into the legislation.
Okay, so you mean the Care Act in terms of the legislation. Okay. And you talked about a range of committees overseeing this,
Yes.
and you mentioned at least 6. Could you name them?
Well, there's I'm sorry about the acronyms.
Don't
the
worry.
GPES IAG, which is the General Practice Extraction System Independent Advisory Group. I apologise if that's not the...
Yeah.
But that's for GP release of data approval. There's the DAG, which is the Data Access Advisory Group. There's the HSCIC CAG, the Confidential Advisory Group. There's the Independent Information Governance Oversight Panel. There's the Expert Reference Group, and there's the Pathfinder Programme Board. And it's all I don't fully understand how they all fit together, but they all have distinct remits and distinct functions.
Does anybody know how they fit together?
Some, but not all of those. I would add the National Information Board on top of that as well,
Oh, right.
and the National Data Guardian.
Well, presumably we can get that from somewhere, can we? As to, not another organogram. Do you want to comment on that, Mr. Smith?
Probably not briefly. They do fit together and there is overlap, I think is possibly the short answer. Hopefully many of those have an affiliation to HSCIC, so they may wish to write to you with the explanation in a diagram, which would actually be very useful clarity for, I think, everybody.
Okay. And this is a kind of general comment to both of you, or all of you, rather a question. So lots of research has been taking place previously prior to Care.data. And I just wondered what's so different that has to happen now in terms of research, because you say it's useful for patients, useful for pharma companies, etc. What's so different now with the research and the evidence and the information that you get that you previously were able to access?
So if Care.data goes ahead, the real difference will be able to link primary and secondary records, so records from GPs and from hospital as well, together with other related data sets, disease registries, prescribing data, and do it on a population level basis. And that's the key difference. These things have happened on a small scale, but if you can do this nationally, you really make use of the NHS unique asset, which is the cradle-to-grave records for 50 million people. And that means you can ask questions at a population level that you just can't ask with limited data sets. It also means that you can ask questions about much smaller groups. You can look at rare diseases or unusual conditions, and where it's difficult to conduct a clinical trial. So, for example, the impacts of prescribed medication during pregnancy, medication in children. It's that kind of question that it's the scale of the data set that really would make the difference. This has been done in a small scale with CPRD already, to add another acronym into the equation.
So for those following, could you say what that is?
That's the Clinical Practice Research Data Link, which is an evolution of GPRD, the General Practice Research Data Link. But what's different about these proposals is that it would open up access to data across all primary care records.
Does anybody want to?
I think it provides, care.data itself provides fantastic opportunities for researchers. This is one reason why we think the benefits, provided the risks are managed properly, the benefits outweigh the risk for improving patient care. And it's the linking of the data sets between the hospital episodes and the care within the practice. That's where the real power lies in the programme.
My concern is what you exactly mentioned. It saves clinical trials, and I just wonder if we're in the process of getting a mass amount of information about the population to save drug companies from doing their clinical trials and doing their work. But there have been some population studies going on, haven't there? So I suppose my question is, what's wrong with, if someone has an idea for a piece of research, just finding out via the GPs or finding out from a different area, which they must have done before, and trying to identify those patients and asking them for their permission if they want to, because I think you'll probably find patients will probably like to help further research. But it seems to me you've got a mass amount of information about people which you don't really need to have, and it just means that people can dip in and dip out. And I'm hoping you're going to tell me that there is an opportunity for patients to know what information has been passed about them.
Perhaps Nicola, you'd be best to address that.
I think there are two slightly different issues within that. You can ask very different questions if you're looking at real-world effects in the population. Of course, there are examples where you can do it on a small scale and ask every individual patient, but you're not going to be eliminating clinical trials here, because this isn't about novel drugs before they've been approved. It's looking at the effects of drugs that are already being prescribed and picking up side effects that wouldn't otherwise be seen if you were just looking at a small population, and it makes that much, much easier. Because one can look at large numbers, the costs and resource implications of asking everybody separately to consent would be huge and would really reduce the amount of research that could be done. You also end up with that sort of opt-in process. You will often have a skewed data set which can lead to an unhelpful and potentially dangerous bias. You'll have some groups that are much more reluctant to give consent, and they're then missing from the data set. So population level data is the most value to get the best possible answers from the research.
But not everybody will be on that particular drug, it seems to me. Say if it's about a drug on the effect of a person or a group of people of that particular drug, and you want to find out how they've gone through the system, you don't have to have information about everybody, do you? And if it's a rare disease, you don't have to have information about people who don't have that rare disease. You can target your research, and people make an application for research, for the information about research. You target it, don't you? You don't just have everyone's information.
You do target it, but
to be very safe is what I'm thinking about people's personal data.
But this helps you target it. If there's one patient in one GP practice, the resource implications for a researcher from a charity or from a university to contact every single GP practice to find out if they have that one patient in their practice is a huge resource implication, and it also puts an added burden on the GP practice to have to be responding to all these separate inquiries. Right. If you can do it at a national level with appropriate safeguards, it's the most effective and efficient way of getting the data.
Yes, and we have to do exactly the same for FOIs. We're continually having to ask CCGs and everybody else under FOI, so there's a huge cost implication for that. So it seems to work for one person and not another. But can I just ask Mr. Smith about this personalised data usage report? Because in your evidence you suggested good news too. Could you just expand a bit about where we are on that?
So a personal data usage report is everybody would like to know where their data has been used, and HSCIC can now tell them. So back in February, you asked them where did they send data this month. They couldn't actually answer the question. Now they can have gone through and worked out, and they can tell you exactly which studies you're in, going to your question of, are you in this rare, do you have this rare condition, or are you in the control group, which is the normal people selected at random from the population for that study. And so that is, where did your data go? You went to these studies. And then, after however long it took them to do the research and publication, this is what we learned as a result of that. And telling patients every single usage. Because when it is everything, what causes concern is that people think things are being hidden. So when it's, we will tell you everything, here's the list, and people can go through and go, I'm not sure about that particular project, but I'm happy with all the others, and I see the government. It's not trusting the governance is good. It's not trusting CAG, it's not trusting the other alphabet soup. It's being able to see, this is what happened, this is where my data went, this is why, and I like those projects. And so if you tell people that, that massively reassures them that they don't have to trust the system, they can read it, they can know. And if you have fundamental consent based in hopefully where we are going, if you opted out of all research, then your research section is empty because you have opted out. You may have been in some studies in the past and they've just published, so you get some, but it's a case of you know where your data is. And if you start having that conversation and providing that electronically to every patient in the country, it's a confidence building measure. So going to Barbara's question earlier, Rose's question earlier about trust and why do we think this is a good idea, it's a case of there is what the Royal Statistical Society calls a data trust deficit. In that if you ask an organisation how much you trust any organisation, and you ask the same person how much you trust this organisation about data, the data one is always a lot lower than the organisation itself. And it's a case of that sort of transparency is a confidence building measure. Sometime last year, some company in London which did breast cancer screening was fined a lot of money because they had a single username and password for the entire company for all of their patient data. That was the front page in the news for the Metro for 2 days because nobody knew who it was. Nobody knew, and it could have been you didn't know. Whereas if you had a list of where your data had gone, for direct care as well as secondary uses, the NHS statement can be, go read your data usage report, and if there's a big red box on page 1 going, this is what happened, click here to find out what happened, what we've done about it, how it affects you, and what you need to do. That would be very reassuring, because it's not a question of, well, that might have been me. It's a bad story, it really shouldn't have happened, but the fear comes from, well, was I involved and what does that affect me? And that's where personalised data usage reports, one of the things they're trying to achieve.
I just want to go back to your, GPs do text. When you go and see your GP, the GP can ask you, so actually the costs are minimal. But I just want one final question, if you don't mind. Given that Korea hacked into Sony, do you think our data is 100% safe? Do you want to go down the line?
I don't think anything can ever be 100% safe, because then you get into really real cases. One of the examples, I was talking to a journalist who writes articles about pharmaceutical companies, and the people he covers know when his wife gave birth and his kid's birthday. He is massively identifiable, and you're giving data to the people he writes about. The only way that you can make it 100% safe for him is for him to be able to opt out, not be in the data set, and his family not to be in the data set. And so you get into edge cases. Is it possible to build a system which is a secure data facility, proper consent check who goes in, data usage reports, and all overseen by a statutory governance? Can that make it safe enough that the vast majority of people go, those are the safeguards, there's all of the benefits come from research, and we like the potential cures and all of the, this is a good thing in a national health service. And I think there is a trade-off that could be found. I don't think the current care data programme is that trade-off. I think it is bits of what HSCIC are doing are moving towards that. But it's a case of that's what this committee and others should have as a conversation of when this is in place. Well, what do we actually want that to look like? And where do we draw the boundaries?
I don't think it can be 100% safe, but I go back to my opening remarks about we have to be beyond reproach. We have to do our absolute best within the constraints of our resources to ensure that it's as safe as it possibly can be. And it should be that the benefits outweigh the risks. And most people understand, most patients are willing to share their data if they're being used for altruistic purposes, to improve other people's care, to find the side effects of drugs or whatever. So it's about making sure that people who do not opt out understand that although it's not 100% safe, it's as damn near safe as we can make it, and that their data is being used for appropriate altruistic purposes, in which case most people will retain trust in the system, in our belief.
I would agree. I don't think we could ever say it's going to be 100% safe, but I think the important thing is if you can't eliminate the risks, to make sure that you can manage them appropriately and proportionately and effectively, and ensuring that the benefits outweigh the risks. I think if I could just come back on Sam's comment about notifying everybody about how their data is used, I think there is a real benefit in having a clear and transparent audit trail, but I think it's worth recognising that it actually personalises the use of your data much more than it actually would be. So if a researcher used your data, they wouldn't know it was your data. They would have a line of code with a whole series of numbers, and it wouldn't look like a person. And my concern would be that if you saw researcher X used my data, people would have a very different impression of what is actually involved when researchers use patient data.
Thank you.
Thank you. Just following up the points that have just been made, I just wonder, Mr. Smith, do you think there's a point at which for you that balance will tip in favour of being confident to share your personal data, well, your data through this programme, or do you feel for you this is just such a fundamental step too far that there's no point at which you'd feel happy to sign up?
I think that decision is made at a different point for everybody.
Yes.
The previous example of the journalist, probably there's nothing you can do for that. And equally, there are people with rare diseases who put all of their medical records fully on the web for free for everybody because it might help somebody.
Yes.
And so those are diametrically opposed, and in likelihood everybody is on the spectrum in the middle. Most people probably don't want to think about it, they just want the right thing to happen. And what does that mean is basically probably the topic of the report from this committee of, well, if somebody doesn't want to pay any attention, what should happen and how is that treated safely? In the same way that when somebody goes to hospital, it's nothing bad would ever happen, but certainly there are processes, and if something happens, well, it's learnt from, and that may be very sad for you or your relative, but equally the whole system as a whole should learn.
I know, take your point that that tipping point will vary from person to person depending on how they feel about these issues. But one of the disadvantages is the more safeguards we pile on, the more bodies we can end up adding to the list. And I think we got to more than 7 in the end when we looked at the number of people with oversight. So do you think if you keep piling in more and more layers of safeguards, in the end you can actually make a programme less effective and without actually adding extra reassurance, I guess? That's an issue as well, you feel?
There should be appropriate governance, and the answer is not constantly adding more bodies is better. There should be statutory oversight of information governance in the NHS again. That, I think, there have been, in the IRGOP 2014 report, there are case studies that going to that point. And I think that's something that should be put back. That's not to say there should be multiple statutory bodies. There should be one based in medical ethics that is responsible for that aspect, which, if care.data had been designed by somebody with a medically ethical background, it would not look anything like it does now. And the programme would probably have been running for 18 months, and some people would have opted out. Those are the people with the most concerns, and everyone else would have probably not noticed.
So that fundamentally was the problem. We started from the wrong place.
The wrong ethos, and it's a case of it was designed to be the most data that they could give to certain types of companies without the public getting unhappy, and they misjudged it.
Thank you. Barbara.
I
I've answered. There's a few mop-up questions just to ask, made confidential, but the others on the panel might want to comment. You've talked about, you've raised with us this question of putting the National Data Guardian on a statutory footing, and you've pointed to a couple of examples from her reports. One where where her group tried to advise on the leaflet, the opt-out leaflet, which was so disastrous, and they were told it had gone to the printers, and that was that. And also that the report indicates that they haven't been able to achieve the cultural change that they call for in relation to information governance yet. So I guess you've just said that you think this should be put on a statutory footing, but what do you see as the main benefit for that?
The main benefit we would see is that when, certainly in that case, NHS England would have had to have consulted IOGOP rather than notifying them after they sent it to be printed. And when somebody can say no rather than say no and be ignored, that is a very different world.
Can I just draw out some other things you said in your briefing that we haven't touched on? You still have concerns about the 9NU4 opt-out code and whether the use of that code will affect the care that you receive. I understand that that is an issue. We've been informed that that is an issue, and that people patients who've opted in that way will have to be written to. Is that your understanding too, and is that still a concern? And
That's still a concern. Just before the committee, I was handed by the clerks a copy of a letter from HSCIC, which goes into more detail than we have seen before. And certainly, we are, as of yesterday when we last checked, NHS England says that opting out with 9U4 will not affect your direct care. And certainly, we believe that that intent could be true. We wait to see the people who give evidence very shortly after us what's there, because I think that is a question you have to ask NHS England.
Yeah, I'm sure we will. You said you haven't seen the list of medicines that are considered sensitive and which will be removed from the data set, and that would be a concern, presumably.
I was told that it would be published in November, within days, and it still hasn't been. So I don't know what's in it. I know when the care data specification was originally published, we went through it in more detail than everyone else had, and the changes tab on their spreadsheet reflects various things that really shouldn't have been in there.
And you've also talked about consultation on the dissemination and use of sensitive data. What we've touched on in previous sessions on this issue is that the most sensitive information in GP records is often GP's handwritten notes, and in fact I raised, I think, in a previous session that there were already research projects that were using those, that were picking up those notes from GP records. So that's still a concern. I mean, what's your view about what audit or what transparency there should be? Because we were certainly told by somebody who knew about particular projects that that was going on, and yet it's undoubtedly the case that the patients involved who were having their notes copied didn't know that that was happening.
Certainly we would hope that every so a patient who opts out of ticks the box of I would like to opt out of everything, can say, well, actually I have this condition and I want to opt into that. And so without looking at a particular case, we can't, if a patient says I'm completely happy for this to go on, in that particular case the most specific objection is the one that should be applied. Or the consent, and you can override them, and it gets very complicated very quickly.
So the question was specifically, should there be uses of that, often much more sensitive handwritten data, not the codes of, dates of birth and conditions and when you were in hospital and what procedures you had, but actually whatever the GP writes down. We found examples, we were given examples of research projects where they were using that information. Is that something that's been discussed in your group, that you've got that you've raised? I had an issue with it. I just wonder if it's.
We recognise many the very obvious issues that come up from there. To say it should never happen is not. But okay, what the question we would look to have, and this will be a conversation with the research community, with the GP community, with the affected patient groups for that organisation, for that condition. It's like, okay, what is appropriate for this case and for this type of project? which is why for general research, the general answer is, well, you go and ask CAG and you possibly ask another body as well, and so what should the process be rather than any particular project? And certainly there should generally be personal consent for looking at notes, but yeah, I'm not aware of a deep process there which possibly doesn't answer your question, Tom.
Might be a question your group could answer rather than questions we should have. Just a final point. I know Made Confidential had a lot of issues about data reuse agreements and the fact that patients nobody would know really who was using their data, because when we asked about it, we weren't always told, or were told people didn't know who was the end user of a data reuse agreement. Do you still have those concerns?
So there are new contracts that came into force a few weeks ago, which do require the people who reuse it to fill in a form. Whether that is all cases, whether that they will be published in a register, we don't yet know. It could be solved. It could be just as much of a problem as it was before. But generally, the main problem with those reuse agreements is the fact that it is commercial reuse. It's the commercial bit that is actually the underlying problem. The reuse is just a second level there.
Okay, thanks for your briefing anyway, it was very helpful. Any final thoughts?
I'm just going to answer Dr. Wollaston's questions about governance, and that is, it is a law of diminishing returns. I think there does come a point where the governance itself prevents the project being discharged either efficiently or effectively. That's one thing. And then in terms of the personal level at which one is prepared to share data, at what point do you reach that tipping point? I think personally we need to wait to see the results of the Pathfinders, and the Pathfinders will be very crucial in ensuring that either care data goes forward or not. And I think there needs to be a very clear review with the Pathfinder result. The Pathfinders are not just a step to implementation, they're actually another opportunity just to pause and say, have we got it right here? Are we answering the right questions? Have we covered all the bases? Have we addressed everybody's concerns before rolling out any further parts of the programme?
Thank you.
But can I just, who does that? Is it NHS England who are going to do that? People who've organised care data? Are they going to say it's a success?
I think it has to be the programme board for the Pathfinders, and that's got representation from all the different stakeholders. It's not just NHSE, but we have a role in the advisory group to say that we think this should be done.
So you would be contributing to that process as a group?
Yes.
And you?
The answer is it is an NHS England question, and they can listen to whoever they like, but it is a decision for NHS England. You cannot write to people, and this is the advice of the Information Commissioner's Office, you can't write to people and go, we might do this. You have to write to them and say you're going to. But equally, if, as with the leaflets, where if the delivery of the leaflets and the letters fails as badly as the leaflets did, well, you have not done fair processing, as it is called, adequately, therefore you cannot extract. So there is a break there, and there is a review of which it was originally 2 steps, then it got merged to 1. I think Dame Fiona has some role in that, of which I'm not entirely sure. The ICO will, of course, take a view, advisory group will take a view, but it is up to NHS England what they take account of, and whether or not there are other factors to take into account there.
And there's no role for the elected representatives?
I would imagine the Secretary of State can take a view, but I'm not quite sure whether Parliament
come
gets
before
a say.
us again.
I suspect that won't stop you.
Thank you. Thank you.
Role for our successive body, perhaps. Any further questions? No? Well, thank you very much. And just before you part, I know I mentioned there'd be an opportunity for you to raise any issues you didn't feel you'd been specifically asked or covered. Was there anything else that you felt we needed to take account of?
The only thing that I wanted to add, when I was asked to give evidence today, I sort of sent a message around the sector asking if there was any real points they'd like me to raise. We all think that it's extremely important to get care.data right, and that needs to take as long as it takes. But in the meantime, I think it's worth drawing the committee's attention to the significant delays that are being caused for researchers accessing information from the information centre. There was a clampdown on any access. HSCIC is now open for business again, and they are getting through the backlog. But in the meantime, there have been a number of significant delays, including accessing data that is non-identifiable, that's at aggregate table level and could be publishable. So I think it's important for you to be aware that these delays are happening and that they're preventing very valuable research as a result of the uncertainties over care.data. So the sooner we can get everything clarified, the better. I think I was inundated with examples from everyone, so I'm very happy to pass any of them on if they would be helpful.
That would be quite helpful to have an idea of what kind of level of delay and how that is impacting on important research and thereby impacting on patients ultimately. So it would be helpful to have a note from you and those you represent about the extent of that.
I'd be happy to do that.
Thank you. And
Just one further question.
NHS England so they know what they've done.
Can I just, you said something about asking the sector. Could you say who you represent?
This was researchers, and it wasn't comprehensive, but particularly across the medical research charity sector.
Right.
So charities were reporting examples that they'd heard from researchers that they're funding.
Okay.
But it was quite a broad range and included some
But
of
it's
them.
useful to have an idea of the kinds of examples and the kind of severity. Are we talking about weeks or are we talking about
Months.
So we're talking about months of delay and also the kinds of projects that are being impacted by this. Can I ask, who do you hold responsible, who would be in a position to shift that and move that on while we're waiting for this to be resolved?
I think some of that is the information centre now, but some is the result of a increasingly complicated and fragmented approval system and people feeling that they're having to duplicate applications and go to a number of different bodies, and because of the uncertainties there's a risk-averse approach to dealing with these applications. So a number of the case studies commented that the individuals at the information centre were being extremely helpful and insightful in their advice, but regardless of that, there was still a number of different approvals processes, and the extra complexities in the data sharing agreements weren't always proportionate for the type of data that was being made available.
Thank you. That's very helpful. Well, thank you for coming this afternoon.
May I just say
yes.
that unfortunately I was only asked last night if I could come to today's session, so we haven't had time to consult our members. But what I would say is that in previous discussions at our council, the members have supported the progress that's been made with care.data.
Thank you.
I think there can be a good outcome, and I hope we get there, because I like the fact that the researchers, Nicola Funds and the institutes and all of the good work that is done produces good outcomes for everybody. It has to be done safely.
Thank you. So good closing comment. Thank you very much. Hello. Good afternoon, and thank you for sitting through the first session as well. It's been very helpful. And I wonder if we could start perhaps by asking you to introduce yourselves and your role to those who are following from outside the room. Thank you. Perhaps David.
So my background is as a clinician. I started my career in general practice and went into psychiatry. I became involved in the world of confidentiality in the 90s. And was involved in producing a report for what was then the NHS executive, which led to the establishment of Caldecott Guardians in all the provider units in the United Kingdom, who I think have played a role in assuring patients that data is kept confidential and used for the purposes for which they've provided it. I then had a break from this particular activity until 2012, when I became the chairman of the National Information Governance Board, which of course at that point only had 18 months to run before it was disestablished. Since then, I've been involved in working for Secretary of State for Health on an information governance review, which came out of the listening exercise for the Health and Social Care Act. And that led to a report which had, I think it was 26 recommendations about how information governance could be improved in the country. And from that came the establishment of the Independent Information Governance Oversight Panel to try to ensure that some of our recommendations were implemented, and indeed the government accepted all of them in 2013, and that's what we've been doing for the last year. And in November, the role of National Data Guardian was established by Secretary of State, and I was asked if I would take it on as the first post holder. It is, as the title describes, it relates to England. It is about health and social care data, and I thought the word guardian was extremely important, because one of the things that's happened in the recent past is a nervousness, if I could use that word, on the part of the public about what happens to their health and social care data. And as a clinician, but also as a patient at times and a member of the public, I recognise the crucial importance of the public having confidence in those they consult about health and their social care needs. And it seemed to some of us that that trust and confidence had weakened, and hence the work that's been done to ensure that the balance between protecting the information, protecting the confidentiality, but also ensuring that information is shared in the patient's interest was acceptable to members of the public, and that that was a balanced exercise. And one of the things we found in the review was that the sharing of information in the patient care user's interest was not as strong as it needed to be to give the best possible care. So I think that's really the background to the new role. It was only established in November. We have worked in the last 2 years with a very small panel. So one of the things that's an issue is the resource to support the work, and that is being considered at the moment. And then, as you've heard already, there is the question of putting the role onto a statutory footing, which does relate to, yes, the independence of the role, but also the authority and the extent to which somebody holding it can exercise that authority and ensure that the standards that we want for the whole of the health and social care system are established throughout that and are in the patient's interest whenever they present to our services.
Thank you. That's a really helpful background. And before I come back with some more detailed questions, perhaps Tim,
sure.
Kelsey, you could set out your role as well. And,
so Tim Kelsey, I'm the National Director for Patients and Information in NHS England. I was also appointed by the Permanent Secretary of the Department of Health to be the National Information Director, which chairs the National Information Board, about whose role I can give you more details should that be necessary. But in addition to that, I'm also the senior responsible owner of Care.Data. And just to make one point clear, the governance for Care.Data, which I think is a very important issue, has been reviewed and amended over the last several months it's actually a national informatics programme. It's not an NHS England programme. And as a national informatics programme, I am accountable to the Informatics Accountable Officer of the Department of Health as SRO for it, who is, of course, then accountable to the Secretary of State directly. And the Secretary of State, of course, takes a great deal of interest in this programme. So just to make the point that when we come to the decision-making process for how the Pathfinder process may or may not be initiated, that it's in the context of a direct line of accountability that goes from me to the Department of Health. NHS England funds part of the programme, but it is not the sole or discretionary decision maker.
Right, thank you very much. And can I just return to you, Dame Fiona? Could you set out for the public in more detail, following on from your initial piece, about how you will be able to hold this system to account and answer the kinds of concerns that you heard raised in the previous panel? What are your powers at the moment? We've heard that you'd like to have those powers on a statutory footing, but as things stand at the moment, as we move towards the Pathfinder projects, are you satisfied that you're able to, if necessary, call that process to a halt? What influence and power do you have to reassure the public?
Well, certainly where the Pathfinder stage of development of care.data is concerned, I have a very clear remit for Secretary of State for Health that I have to be satisfied that the conditions that we have put to the care.data programme board in order for any data to flow from general practices to the Health and Social Care Information Centre are met. Mm-hmm. So that piece of responsibility is very clear. We already had it under the Independent Governance, Information Governance Oversight Panel in relation to care.data, but it's been strengthened in the words around the National Data Guardian. In terms of authority in other respects, I would say that this is to a large extent to do with building good working relationships. There's a clear remit in the terms of reference as drafted, they're still at draft stage, to work with the Information Commissioner's Office and with the Care Quality Commission, because of course they do have statutory powers. And there's an expectation that if we encounter issues which we think are not in the public's interest, we are able to refer them through partnership working, if you like, to whichever of those bodies is the most appropriate. So there are some powers in terms of trying to influence, and I think it's clear to me already that CQC and ICO are going to take that relationship seriously. We're setting up meetings to look at how the working together will operate and may well reach the need for a memorandum of understanding. But there's a lot of goodwill in the system, I would say, while we're not a statutory body or person, to ensure that we are able to advise where appropriate, strong links with the National Information Board, with the New Information Governance Alliance and other bodies within the system. And I feel confident that going forward, because of the strengthening of the role, even though it's not statutory, that more notice will be taken of what we have to say.
Thank you. I know that we're going to come later to the 27 points that you raised, so I won't pursue that point now. But I wonder if we could come to...
Sorry.
Yes, sorry, Tim.
Just to make the point that although it may not be statutory, the objective of this entire programme since we brought it to a halt, since subsequently I became SRO, has been to co-produce on the most fundamental level in every direction both the design and I'm sure we'll come to the cultural issue that's raised earlier, but the culture of the programme is fundamentally committed to a level of co-production and oversight on a scale and with a commitment frankly I haven't often seen in public service programmes. And just to make the point that regardless of statutory authority, the programme board will only proceed with this if Dame Fiona is satisfied. The CMO has also, as it were, who we had invited as the programme board to take an independent view. The Chief Medical Officer has in fact passed on that responsibility to Dame Fiona as well. So it's a very fundamental part of the commitment. We have to be as open and transparent and committed to just getting this right. So it may not be statutory, but we are bound by Fiona's position.
Thank you for clarifying that. Barbara,
Yes, it may not be a question you can answer, but I have to say I don't see a reason for it not to be on a statutory footing. And I understand the Minister has said it will be done at the first suitable legislative opportunity. I think we were chatting amongst ourselves before the panel started, and we think that could be next week, because this Parliament has so little to do at the moment, apart from meetings and the hard work that we do on this committee. But because the concerns that were highlighted in your report, the two things, the fact that you tried to stop the disastrous leaflet going out last December, January, that would have, been a very sensible thing to do because it was a disaster, and we're told it had already gone to the printers, and the points about cultural change. I mean, do you believe, Dame Fiona, that it would be right to put your role on a statutory footing?
I do, and can I take this opportunity to say how much I welcome the support that's coming from the political parties, because initially I think the suggestion came from members of the public and from Ed Confidential, but the support for that development has grown until the discussions on Mr Lefroy's bill, when I think both of the major parties support it. I think it would be very helpful. You think of the February leaflet as a little bit of a low point, or quite a bit of a low point.
Yeah, we thought that too.
And I think there was a lot of learning from that. But as the year has gone on, I would say that, as Mr Kelsey has said, there has been more acknowledgement that there are those of us within the system who are very concerned to get this right for patients. And I think there has been closer working, but nonetheless, I think there is an opportunity in the statutory nature of it, which I certainly learnt as chairman of the NIGB for the 18 months that I did it, that it's possible then to have all the key people in the room and for the work that you do to be promulgated out to where it will be most useful and to be taken real notice of. So I've had that experience, which leads me to think that this would be a very welcome development, given the developments that have taken place in information technology in all the recent years, where the public is much more alert to the possible dangers to their information, and want to know the answers, as you've already heard in the earlier sessions and in your previous hearings. So I think we're at a point where we can't avoid strengthening the reassurance to the public that there is someone with a body supporting him or her that is actually giving this issue trust in the system and how the data is safeguarded and then appropriately used as much attention as it deserves, with the people who are trying to implement change and do all the things that we want to be done in the interests of improving health and social care.
Thank you. Come on to David.
Mr. Kelsey. I wanted to focus on I want to talk to you about the basis for selecting the Pathfinder areas. Can you give us an indication of how this is done?
Yes, I mean, this, by its nature, is rather a complex programme, so let me just give you some straight facts about how the process. So there was a selection panel for the selection of the Pathfinders that consisted of the RCGP, the BMA, Healthwatch England, and also a number of NHS England's voluntary sector partners, which is a group that NHS England has brought together. Subsequent to their independent selection of the Pathfinders after volunteering had taken place, so Pathfinders volunteered. One of the criteria, going to the point of thinking about patient involvement, was that in order to be accepted after having volunteered potentially as a Pathfinder, you had to have the assurance from your local health watch that they felt properly engaged, and your patient participation groups from GP practice and the Pathfinders also had to give an assurance that they had been involved in the development of the proposal.
Mr Kelsey, can I just clarify one point? Were people invited to volunteer, or was there a universal invitation for all CCGs to volunteer? Because there's a difference.
Yeah, well,
if you don't know you could volunteer, it's different.
So what actually we wanted this to be a very concentrated experiment, really, in setting a new standard for fare processing.
So in other words,
so we were approached by unexpectedly by rather a large number of CCGs.
But did every CCG know that they could have volunteered, or were certain CCGs approached and tapped on the shoulder and told that they should volunteer?
No, we didn't tap CCGs on the shoulder, but neither did every CCG. I can't tell you whether every CCG knew. We announced our intention to run Pathfinders, but we were approached very quickly by quite a large number of them. So in the end,
Sorry, that's not a very
Does that
clear
make-
answer.
no.
So there's a difference between putting out a general notice saying we're looking for volunteers. There's a difference between that and phoning up a selection who you would quite like to be the volunteers and saying, could you please apply? So, you know, either you have a general open, everybody knows there's an opportunity to volunteer, or you're having a self-selected group selected by a group of people who've decided they'd like these people to volunteer.
Yeah,
There's
or-
an important difference, surely.
No, I agree, but what actually happened was that a group of CCGs, aware that we were moving to this phase, although we hadn't publicly announced it, through things like the
So
Commissioning
how were they
Assembly.
aware? Were they aware because somebody phoned them up? No, but
Pardon?
what I mean is, were
Yeah,
they?
okay.
Did somebody make them aware? There is a difference, clearly.
Yeah, well, it was very widely known amongst the commissioning community.
How
that-
was it widely known? By word of mouth?
I'll find out, but it wasn't. No. It was
that's not that. No,
it's-
what I mean is, there's a difference, isn't there, between approaching people and saying we've got this opportunity for you to apply,
Yeah.
and that being by phone call or email to individuals.
Let me- I will investigate
I think it
how
would
that
just
was-
be
of
helpful
course.
to know because it is it's of interest.
No, I totally understand
how
that.
this was selected.
But there was a completely. I will find out.
Yeah.
Chairman, can I just say, this goes to the heart of where the distrust comes, because statements are made throughout these hearings, and when you test them, they fall apart like this. You can't say they volunteered to do it and not. It falls apart, but then you not know the detail of whether they did or they didn't.
Well, they all volunteered, and they were then independently assessed by a group of independent people.
But self-selected.
They self-selected on. They self-selected.
You didn't go out as volunteers, they self-selected themselves.
That's correct.
Okay, should we proceed, Chair? Thank you. Okay, so we've established that. Do you know how many of the practices in those areas will be taking part in the Pathfinder project?
Well, at the moment, 80 practices in 3 Pathfinder areas have said they want to participate.
Yeah.
We anticipate it being significantly more, but obviously they are currently. It varies by different CCG area how far they have got in their activity and their conversations with different practices. So I think in West Hampshire with Blackburn and Darwin, I think all GP practices are participating. In West Hampshire, I can provide the figures for the current state of play. Obviously, it varies on a day-by-day basis. But as today, it is 80 practices who have said they wish to participate.
Right, and just before I hand back to the Chair, is there anything about this process that you would do differently now that you've been through it?
For the Pathfinder
Yes, I mean,
selection.
now that you've looked at this, we've had 1 or 2 concerns raised here this afternoon about selection. Is there, and you're going to write to us, I think, about that,
Yeah.
I imagine. I just wondered if you, with what you know now, whether you would have done things differently at this stage.
No, I don't think so.
Okay.
I feel
Fair
we
enough.
have, and you must. I mean, the CCGs aren't represented on the table here. They've all provided me with their. I mean, it's a shame the CCG chairs aren't here, but the process of their selection was robust. It was independent, and as SRO, I feel that I wouldn't have changed it.
Thank you.
There was a question raised to the previous panel, which I don't know whether you can answer, and that was whether or not the Pathfinder's going to be paid or not. Simply the last panel couldn't answer it, so I wondered whether you were able to.
Yeah, so I actually just was in the back as you asked that question, and we will provide the committee with a note of the amount of money which may or may not be paid to Pathfinders for material production and so on. So they're not being paid as a CCG, but we have agreed to subsidise some of the costs of the evaluation. For example, we have Ipsos Mori running polls with the public. We have a range of surveys with patient participation groups to ensure that Dame Fiona is able to evaluate the degree to which people were informed, and those costs we have agreed to bear centrally, and I can provide an accounting for that.
Thank you.
You just said some of the costs. Are you
Yeah.
going to meet the costs or some of the costs?
Some of the costs.
So patients in the CCG will be contributing roughly what?
No, so things like GP practices have existing legal obligations, as we've discussed, to do certain types of fair processing. So we're not subsidising them, for example, to speak to their patients to... we are subsidising aspects of this in order that we can test it. That includes we are contributing or paying for the costs of letters to go to each patient and the evaluation that surrounds that. We're also paying, as I said, for other points of evaluation which we've agreed with the CCGs.
So, whilst I appreciate that, can you give us any feel and any rough figures? You know, what would a CCG be contributing? Would actually be contributing to this?
I can't answer that question, but we will very rapidly come back to you with the CCG's own estimates of what the costs of this programme are and how much of that cost is being met by NHS England, or by the programme, I should say.
And I've been asked just to clarify, it's Blackburn with Darwen, Hampshire, and all of Leeds?
Yes, so it's so there are 7 CCGs in 4 geographic areas. So it's the 3 CCGs in Leeds, it's Blackburn with Darwen, it's West Hampshire, and it's Somerset.
And which of these 3 Pathfinder areas are the ones that you've got 80 practices so far signed up from?
So they are in the West Hampshire, Somerset and Blackburn with Darwen areas. Leeds is developing some proposals which it wants to test with its GPs first. So it hasn't yet started the recruitment process.
I'm just a bit confused. You're running a pilot, but you haven't put up, you don't know what the costs are.
Well, I know what my costs. I know what the costs of the central programme are. I don't know what the costs are.
Of the Pathfinders, you don't know what the costs of the Pathfinders are. You just said you write to us and tell us about it. But surely you must have put a bid up to someone, Secretary of State, NHS England. You must have said, this is what the Pathfinders are going to cost. What is the cost of that?
Yes, I can give you that. I know what the cost to NHS England or to the programme is for the Pathfinder.
Which presumably is covering the
But that doesn't cover
letters.
all the costs of the opportunity cost for training for GPs in a CCG.
But why not? Because presumably it's a Pathfinder. You must have a project in mind. You must have the amount of money that you want to spend on it. Because you're spending the money. You're saying you're subsidising the CCGs. You must know how much it's going to cost.
I do know. I know exactly how much it's going to cost for...
But you just said you didn't know.
No, but sorry, I thought I was being asked the total cost to the local NHS of fare processing in relation to care.data, and I can tell you the costs that are being provided by NHS England, but individual CCGs are additionally spending, or local GP practices are, of course, engaging in costed activity in order to meet the fair processing requirements.
Which you're subsidising, which you've just said.
No, not all of them, because some of them are legal responsibilities of... Yeah.
So you must know what the costs of the sum.
Yes, I do know the
Why are you
costs
not
of the
doing
sum.
it all? If you're asking them to do something. I just find this horrifying. Is that how NHS England operate? They don't know how much things cost.
Yeah, no. Okay, so to be clear, I know how much the programme costs from the care.data perspective, but these are legal. So an individual GP has an existing legal responsibility to fair process consents or opt-outs with local patients, and that's part of their existing responsibility. So when the care.data programme initiates, we're not, as it were, recruiting staff to help them do that.
I'm talking about Pathfinders.
Yeah,
I'm
in the
talking
Pathfinders.
about this project that you're trying to evaluate.
Yeah.
You must know how much it's going to cost and how much you're going to subsidise people to find this information, how much the evaluation is going to cost. You must have said that to someone in NHS England. You must have gone back and said this whole project is going to cost so-and-so.
Yeah, okay.
So who signs the cheque for that? Someone must have written that off, or someone must be signing it off.
Yeah, so we have a programme budget for care.data, and I can provide you with all the details of that, absolutely.
And the Pathfinders, particularly Pathfinders. That's what we're asking about.
Yes, and the costs
There's a confusion, Mr. Kelsey, about whether you're subsidising or whether you're not subsidising. You're saying you're helping some CCGs, but then you're saying you're not really helping them. They're doing it themselves, but you're going to pay for the postage, but you're not going to pay for something else, but you're paying for the training, but you're not going to pay for other things. We need a bit of clarity, please.
Sure, that's what I said. I will provide that.
So you'll
What will make this Pathfinder project attractive to a CCG that, as you say, they by osmosis they found out about it and have thrown themselves at your door to do, and you're not paying for it all, so, and it's going to be at some cost to them. So what is it about this Pathfinder process that would make a CCG want to be involved?
Well, perhaps I could just read a statement from Sarah Schofield, who's the chairman of the West Hampshire CCG and the project. So what she said is that, understanding that would be a question for the committee today, is that this is her message to the committee, is the sharing of patient information across the NHS helps to ensure that the quality and safety of services is consistent and provides valuable insight on diseases and conditions. It is essential that this is done in an appropriate and secure way. We are therefore extremely pleased to have the opportunity to work with our patients to test communications on care.data and ensure GPs are equipped to manage this locally and are able to support patients with making informed choices.
So she'd prefer to do that than to put some money into some I don't know what, some procedure or other that patients could direct. What would make a CCG want to contribute money to your project other than why? If you told them they were going to do it, I could understand. But they're volunteering to be part of it, yes, in principle, but they're not benefiting. It's going to cost them, you're suggesting. So why would they do it?
Yeah, well, they very much hope to benefit, because as commissioners of services...
But all the other CCGs who aren't Pathfinders and aren't doing it will get the benefit of whatever comes out of this, and it won't cost them any money or any time, effort, whatever. I can't understand. What is the hook that would attract them to it?
Well, I think hopefully it's communicated there, and to such a degree, perhaps the committee needs to just sit down with the CCG chairs. But the truth is, commissioners and GPs want to, safely, but as quickly as possible, in a sense, get data to flow in the NHS that enables them to make better decisions to improve care for their patients. So these Pathfinders have volunteered, have self-selected, gone through a process which has been relatively arduous, so we can defend the selection of the CCGs in order to educate themselves as to how best this should happen. It is an experiment. It's not my project, nor is it NHS England's project. It's a project of 4 CCGs, 7 CCGs, 4 regions in which there are 250 GP practices who want to learn how best to do this and meet the new standard that Dame Fiona has set in relation to fair processing for patients.
Right, so they want to do it for the greater good is the impression from the letter you've read out. Right, okay. Right, Barbara?
Well, I think there's a point of clarity needed. You said that you weren't aware how many GP practices from Leeds wanted to opt in or not opt out because Leeds is developing its own proposals that it wants to test. Is that something extra? What is it that they want to test?
So this, I said at the beginning that the premise behind the redesign of the entire programme has been around co-production, co-creation with local frontline services. And so each of the CCGs has developed sort of variations with different communities, some are rural, some are urban, variations on the kind of strategy they think would be appropriate as GPs to meet their obligations, as I say, with support from NHS England. In Leeds, as a city, what it wants to do is really test actually some digital solutions for giving people granular opportunities to opt out. And so it's developing those proposals with the GP community. It hasn't yet got to the point where it's actually recruiting GPs to test out those proposals. So it will do over the next few weeks, and obviously we'll be very happy to keep you updated on the process of their selection.
And the GP practices in Leeds and elsewhere can opt out?
Say again, sorry?
The GP practices in Leeds and elsewhere can opt out if they want to?
Yes, it's voluntary. It's entirely voluntary.
That wasn't clear, because there was a stage in all of this when it seemed like pressure would be put on GP practices if they did try to opt out.
To be clear, in the Pathfinder stage, this is a voluntary exercise to test the new approach to communicating the opt-out rights to patients. GPs are not being forced to participate at all.
Yeah. Okay, well, the question I've got was, and it might be, I don't know how easy it is to answer, what precisely you want to learn from the Pathfinders. I have to say, I think I must have mentioned before in all of this work that I used to work in IT, but we had customers that were, leading edge, would always want to test things. It doesn't test something absolutely, that you get the real, keen people who self-select. That's not the acid test, is it really? Because the ones who don't want to be first, the ones who are last in the queue, that are not very keen on this, are not going to, it's not going to work as well. So I'm sure you will learn something from them, but I have to say I'm uncomfortable with that process. I would be more comfortable with it if you'd offered other areas chances, because I think there's always a danger in only working with the leading edge. But if you could tell us what you do want to learn from the Pathfinders.
Well, this is why actually I've really welcomed the report from Dame Fiona, because that set out some very clear standards that need to be achieved by the local NHS to properly both safeguard, properly explain the opt-out rights that we're providing patients, and so to what the learning we need to get from the first Pathfinder phase, and there may be more. I mean, there is no artificial deadline for national rollout, so we just don't know what happens next. But this Pathfinder phase is intended to test the degree to which Dame Fiona and her colleagues on IGOP feel that we are achieving, have achieved, need to do more to achieve a proper standard of fair processing. So those are the 27 recommendations, and they need to be achieved and independently assessed. That is the purpose of the Pathfinder stage.
So is the plan to use the data extracted in any way in the Pathfinders, perhaps for planning, health and social care, or are they simply testing the processes? Is it just communications, the leaflet, opt-out, how it works with the GPs and so on?
So there are two parts. The first is indeed to test the quality of fair processing against the standards that the Dame Fiona set. But the second part, which the Care.Data Advisory Group and others are very keen we also do, and Sam mentioned this in his earlier evidence, is that we do, in the extraction of the data from these limited number of practices, which will be held in a totally locked down, secure environment, as I think you're aware, that we should run some analytics over them in order to demonstrate that there is actual value in the data as well. So the evaluation of fair processing is on the one hand, but on the other, we have already constructed an independent expert group who will look at the sort of outputs of the data analysis and confirm whether or not indeed the hypothesis or the evidence that says that linking this data can support improvements in the quality of local services is to some extent evidenced.
And is it only for that, or is there any intention or plan to get into end user, commercial users?
No.
Absolutely nothing?
No.
And how is that guaranteed?
So it's guaranteed because the data will be held, there will be no access to that data that flows from the Pathfinder practice other than in the secure data environment. And there will only be researchers who are identified, I think, already from 3 organisations, and I will, in my notes, which is NHS England, the Health and Social Care Information Centre, and PHE, Public Health England.
Okay. Thank you, Rosie.
Thank you. In the previous comments, we talked about attempts at communicating with patients being a low point, and I suppose that's where I came into it. So I just wondered whether the communications to patients for the Pathfinder areas, have they been finalised? Are they going to be different in those different areas?
Well, I was really reassured to hear some of the comments made earlier. So we feel we have done an enormous amount of, as I say, co-production with GPs, voluntary groups, Healthwatch, various others to develop the materials. I mean, just to get it on the record, actually more than 3,000 people in 180 workshops across the country have helped develop these areas. And in the CCG areas that are Pathfinders, they've also been running their own independent engagement with voluntary organisations and patient advocate groups and so on. So I think collectively we feel with the CCG partners that we have got the materials to a place which is unrecognisably better than the previous place we were in. But obviously part of the Pathfinder test will be to establish that that's actually measurably the case, and if we need to improve them further, then obviously do so.
So short-circuiting version of that answer is yes, you have developed it and you've got some. So has the Independent Information Governance Oversight Panel seen those proposed communications, and what's its view?
We have seen some back in November, December, but we understand there is even further refinement happening, and we haven't yet seen the further refinement.
What was your opinion of the
It was certainly better. More clear, but still, I think, lacking the sort of clarity that we would like to see. It's quite a complicated thing to explain to, dare I say, the average member of the public. This isn't simple. I think it's not quite like explaining, for instance, the issue of consent to a procedure. It's more complex than that. So I think there's quite a challenge for those who are preparing the material to get it absolutely clear what the patients are being asked to agree to or to opt out of. And there's certainly been progress through the meetings that Mr. Kelsey describes. So what we saw before Christmas was better, but we think could be better still.
And just to say that we have taken, well, I hope that this committee will, over time, recognise the seriousness with which it took one particular aspect of this, as well as the broader issue, which was around accessibility for disabled groups. And we really have, I'm just looking at the list here again, which perhaps I can make available subsequently, of all the organisations that have been involved in helping us shape these materials for specific interest groups and constituencies, in order that we can absolutely help GPs discharge the responsibility that we have to the entire community, not just to those who are able-bodied or able to read.
I think it's a really difficult thing, and I actually looked at Med Confidential because I've opted out, as you know. I totally approve of this project, absolutely, 100% behind the principles. I think the way it's been handled is an absolute disgrace. I don't need to go into that again, and I've opted out. But I looked at Med Confidential's advice on the various levels of opting out, and our exchanges at previous committees just made me absolutely confirm that I did do that. But I suppose I'd really like to go on to ask what has been done to make the process of registering an objection transparent, straightforward? Are you trying different forms of wording?
Yeah.
And then I'd like to go on to the impact of that after.
So we've done an enormous amount of testing of the wording for the opt-out. Sam mentioned that as well. It's been, the individual CCGs have tested it with all sorts of constituencies. We are very close now to resolving a form of words which appear to both be very accessible and explain simply what the opt-out now is. We've also changed, it's not just a matter of communications, it was also fundamentally changing what the opt-out meant. So as before, in the previous iteration of this programme, there were 2 layers of opt-out. There is now just one opt-out, and the opt-out means that no identifiable data will leave the GP practice at all and transfer to the information centre, which obviously makes the job of explaining it much more straightforward. So again, and a very important part of the evaluation of the Pathfinder phase in relation to fair processing is whether people feel they did understand and were informed by the form of words we've used, and actually also did understand the simplification of the opt-out that is now being decided upon.
Now that is very good news, and I think that really does take the onion down to its most meaningful level. But could you now explain to me, it's now one level of opt-out.
Yeah.
What does that actually mean to my care and my treatment? In previous panels, you've suggested the GP wouldn't get paid, you wouldn't be part of, sort of reviewing, sort of screening programs. That's the word I'm looking for. That kind of thing was the suggestion. So, if I opt out, what will happen to my care?
So, to be absolutely clear, there will be no impact at all upon your eligibility or entitlement to treatment on the NHS, and insofar as clinicians are exchanging data for that treatment, this has no impact on it at all. So direct care is in no way affected if you choose to opt out of care.data at all. Care.data the opt-out of care.data relates to the secondary uses, as we sometimes call it, of data for analysis to support the improvement of quality in local services, and as Nicola said, also for benefits in research territories. Now, the Chief Medical Officer would argue, and many others do, that in the longer term, if large numbers of people opt out, that will impact on the ability of the NHS to improve the quality of care provided, and in that sense could affect your care in the future. But it in no way affects the treatment that you will receive on the NHS if you choose to opt out.
That is really very good news. So, are you consulting patients before you rolling out these plans in the Pathfinder areas? Are patients going to be involved sooner rather than later?
So the CCGs and the local GPs are working as local consortia with a large number of different sorts of voluntary organisations, obviously to some extent dependent upon where they are, but all of them are working with Healthwatch in their local health watches. And actually one criteria for selection of the CCGs was that there was a good active local health watch that could properly represent the views of local communities. So patients are fundamentally involved in the way the process has been designed.
The Health Watch is new, and you couldn't really say they've got a great reach into communities right now, I wouldn't have thought.
I think it varies. I think some are very effective indeed, and certainly my own experience of the Pathfinder areas and the health watchers that are involved there is both of them being very active. Obviously, people are working under considerable resource constraints, but they're very active, very committed to trying to get this right. So I think the partnership that's been developed in response to the decision to sort of stop the programme last year has been a very good demonstration of the way in which local health communities are getting together for the right reasons.
So could you explain to me just exactly what that patient engagement via Health Watch, what's it really mean? It's a nice flowing sentence, but what's actually going on the ground?
A lot. I mean, I'm wondering actually whether or not we should arrange for the committee to come and see a Pathfinder and talk directly to those involved, because they really are very active. So I'm just trying to find the right page for West Hampshire.
Perhaps while you're doing that, Tim, I've had a meeting in our locality, not a Pathfinder locality, to discuss the Care.Data programme last autumn, and Health Watch, this was for Oxfordshire, was very active in getting together 200 of the public locally to come and debate the issues. So I think, as is being said, there's tremendous variation, and if it's an active team running the Health Watch, then it can be done. But
absolutely. I suppose that's really why the follow-up question, to really find out what is going on, what has happened in those areas. Because
well, literally, so I'm sorry, I'm just trying to find the paper. So in West Hampshire CCG, there have been 16 meetings since October with involving all 51 GP practices, patient participation groups, Health Watch, the local medical committee, CCG board and internal staff, in order to explicitly develop the materials, develop strategy. It has been a consensus-based approach to...
Mr Kelsey, they're all the usual suspects. Where's the public?
Well, so... I think the patient participation groups for each GP practice are there to represent the public. So those are the independent bodies which most practices, I think all practices now have to have. So I think, again, it's perhaps a question for the CCGs in a way, but I think the public is...
again?
I don't think so. I think most patient participation groups are relatively representative of the local community.
There might be one or two people. I'm engaged in health, chair of a hospital, all the rest of it. I couldn't tell you who my patient representatives at my GP practice is. Don't communicate with me, so I'm a member of the public. How do I know?
Yeah. Well, all I can say is that when I've been to practices and have engaged with the patient participation groups in those practices who are contractually required to exist by the under the GP contract, they've been very robust and
No, the point I'm making is you're talking to the health population. You're not going out there to real people who are not engaged in health, who are not sitting there worrying about health matters day in, day out. These are the people that you're missing altogether.
Well,
98% of the population.
So outside of those particular local engagement exercises, we have been supporting a whole range of national exercises that have brought together, as I said, about 3,000 people from all walks of life, absolutely the general public. I went to a meeting with Sam's colleague, Phil Booth from Med Confidential in Manchester, which was an open meeting for the public to debate some of these issues. It was a pretty robust conversation, as you can imagine. People are genuinely interested in understanding, A, what we've done, holding us to account for what went wrong initially. And so my experience has been of a pretty open and frank level of debate in which we have very actively tried to make sure that the general public are, here we go, we've had, have been engaged. And in addition to those meetings, the advisory group, the Care.Data advisory group, has also hosted 3 open events on its own initiative, which have involved more than 200 members of the public in Peterborough, London and Manchester. So I think we really have tried, and I think the net result of that is that certainly the oversight, that those people who are very helpfully giving us constructive challenge, like the advisory group, like the programme board, like Dame Fiona, are, I hope, beginning to feel that we are making some progress, though yet more progress needs to be made.
Okay, could I just return to a point you made earlier, Mr. Kelsey, about opting out not affecting your direct care?
Yeah.
But of course, opting out of some types of type 2 data could affect your care if it means you're not going to be approached, say, and offered bowel screening, or you're not going to have the opportunity to take part in e-prescribing, or so there are some implications. And will that be made very clear to people? In fact, some concerns have been raised to this committee in advance of the hearing about data, type 2 data, leaving the Health and Social Care Information Centre for patients who have actually opted out. And obviously there are quite complex reasons behind that, and I wonder perhaps whether so I know you will now have seen the letter from the Health and Social Care Information Centre, and I wonder whether both you, Mr. Kelsey, and Dame Fiona, you'd like to comment on that. I know it's quite a complex area, but I think it's an important one.
I got back to you earlier, and you said it would not interfere with.
Yeah, no. So so I think from a care, I can only really speak for the care.data programme, to be honest. And from the care.data programme, there is now just one type of objection. Data does not leave the GP practice if you choose to raise that objection. That is the opt-out that will be offered in the Pathfinder areas and tested.
Right.
I'm not that familiar, to be absolutely honest, although I've seen the letter with the arrangements that HISIC has got for allowing people to opt out of data that it stores.
But you shouldn't give assurances if it's not 100%. That's why we're in this mess. When you say something categorically, say it, mean it, be 100%.
But I think, with respect, Rosie, I mean, there are two issues here. There's one that's been raised with us about whether or not, at the moment, care, data
care
is leaving the Health and Social Care Information Centre for people who thought they'd opted out. Whether that's happening, or whether or not people are unaware that because of what they opted out of, that actually it means they may not have realised that they had opted out of being approached to be offered bowel screening. So I think that it would be nice if you could clear up the situation with where we are now. Is data leaving for people who thought they'd opted out? What's happening with those people where the data's not leaving but they were unaware that it meant that they weren't being approached for bowel screening? And then there's the separate issue
Perhaps
on
I can help,
the future
Chairman.
situation.
This was a letter from the chairman of the Information Centre, which was only yesterday's date, and I don't think everyone has had the chance to read it. So, as I understand it from Mr. Manning, in the case of type 2 objections, which have already been lodged with GP practices, the care.data programme board decided in November that the HSCIC should put in place an appropriate process. And they've found, I think it's in the letter, that there are just about 100 patients who had made that objection already. And because of the implications which you've just outlined, they're writing to all of those patients to discuss with them the effects of that opt-out and what they want to do in response to it.
Right.
So in that
in
sense,
other words, it's not leaving, but they might have been unaware that would have implications
They
for
may
them.
wish to make a different sort of decision, but it's something that's only just been brought to, I think, your attention, all our attention, in the last 24 hours, so it's quite difficult to take it further.
As far as you're aware, sort of the person who's, if you like, being entrusted to keep an eye on the system, are you confident that there isn't data leaving the Health and Social Care Information Centre on behalf of people who thought they had said they didn't want their data being shared?
I am confident.
Thank you.
On the basis of what I've been told in the very recent past in relation to the question.
Indeed, so we can answer that those who've raised that with the committee, that it's not currently leaving and being shared, but for those where that could have implications they're unaware of, they're being written to explain the implications of that.
About 100 people.
And then moving to the separate point, which is for the future, for the Pathfinders, you can give us complete reassurance that those who decide to opt out will still have access to, for example, being approached to be offered screening. It won't impact on their ability to be included in the screening programmes.
Yeah, no, it won't.
Right. Thank you. Those were the issues I wanted to clear up. I
Thank
think
you.
that's
Could I just clarify? We've had that figure of 100. Is that 100 in the Pathfinder areas or 100 in the whole country?
As I understand it, it's all together. From this letter.
It's just that sometimes people approach the committee and say they believe that data is leaving. And I mean, if if there are people approaching us who say to us they believe data's leaving the Health and Social Care Information Centre without consent, clearly that's a really serious allegation, and I wanted to be sure from you, Dame Fiona, that we could say you've looked at this issue and you don't believe that's the case.
That is my understanding on what I've heard from the Information Centre chairman.
Right, thank you. And I think... sorry, did you have
Yes, I've got the structure of
Dame
Fiona. Can I just follow up on that, Dame Fiona? And what are the implications then?
Well, there is this issue about the sorts of interventions that Dr. Wallison has mentioned, like bowel screening and aspects of medication prescribing and so on. So, although the assertion has been made in the past that opting out, type 1 and type 2 as they were known, would have no implications for your direct care, it does look as if there are implications for this small group of patients, and that's what's just come to light.
Right.
So that's why there needs to be
I just want to be clear what those implications are.
That means to do with these particular aspects of what can be considered to be direct care.
Right, and I know it's nothing to do with you, but the letter that goes out is quite important, isn't it?
Absolutely.
We would like, I don't know if you get to see that letter, do you?
I hope I will. I'm meeting the chairman on Friday and I will ask that I see the letter.
And we presumably we'd like
you would see it.
Yes, and perhaps we'd like, you could ask them to send one to us. Thank you very much. Can I just clarify now? I just want to move to your role as guardian of all this. You were appointed by the Secretary of State. That was very much on the basis of the good work that you've done previously. And so what was your job description?
Haven't got that yet. Okay. We've been discussing it. I've got it written in broad terms of the role in relation to the public, preserving trust in how the data is going to be safeguarded and how it will be shared appropriately. But it's written quite generally, and we're working now on the job description and also the fact that the independent Information Governance Oversight Panel will become in due course an advisory panel to me as National Data Guardian, because clearly you can't do all these things as a single person. You need to have experts who you can... So that's work in progress.
Right. Okay. So I wish I could get jobs like that, where you can write your own job description and you're just given the job.
I'm contributing.
But no, I mean you've got your absolutely fantastic CV anyway. But I just wanted to clarify how that came about.
Yes.
And so I'm sort of slightly confused about, are you the guardian of the data that leaves HSCIC, and are you also the guardian just for care.data?
I'm the guardian of data generally, so it goes well beyond care.data, whether it's health and or social care data that the person gives to those they're consulting and who are then responsible for it and its use, all of that data. So it's quite a big remit.
Yes. And you mentioned one panel. How many have you got? I think you said it was already formed, didn't you?
Sorry.
Are there people on the panel? How many?
I've had a small panel in the previous role, and it has about, I think it's 8 or 9 members, the names of whom you can find at the back of our annual report. We think we need a slightly larger panel. We lost our member representing local government who had to resign for personal reasons. So we've got some gaps at the moment, and we're building the panel to make sure that all of the, if you like, elements of the health and social care system are represented, because it is necessary to have that input of people who really understand the detail of how these things relate to each other. They haven't been on the previous panel and won't in the future because of our independence be representing anyone, but they will inevitably come from particular groups of professionals and or the public. So we're thinking about that at the moment.
Right. And so you're sort of gauging the expertise that you need on the panel.
Exactly.
And so do you have a secretariat, or is this what you're talking about?
That's resources? When I talk about resource, it's largely people who will help us do the work, organise meetings, prepare papers, help us all get to where we should be to come and do the work. And yes, at the moment it's a tiny team, and we will need more people to fulfil the brief that we've been given.
Sounds like it. And are they coming from the NHS England at the minute, Department of Health? Where are they coming from?
Independent consultant in the role of director, and 1 or 2 people, yes, who have either been in the information centre or other parts of the existing system.
Okay. And I don't know if I think you might have been here earlier where Professor Mathers talked about this 6 committees.
Yes,
now, how does it all fit in with what you do and what you've been tasked?
Well, we could produce you a very nice diagram. I think one of the things that's been very reassuring in the last few months is the report that came out of the National Information Board, which shows how the parts of the system relate to each other. So we're at the right-hand end of the page with an assurance role, and then there's the strategic developmental left-hand side of the page, which is NIB, and the information governance. I can't remember what IGOG stands for now, but anyway, that's under the aegis of Mr. Cavendish and Mr. Kelsey, and then in the middle there's a group of people like the Information Governance Alliance, which is producing guidance for the system. So once they've been given a task, like produce a good glossary that we can all sign up to and agree means the same things to everyone, they will check it with us for assurance, but in the end that will be a joint production between, if you like, the 3 arms. So the strategic group commissions work, the middle group does some work, we're involved in the iteration, if you like, of that to get it to a state where we can say, yes, you can have the imprimatur now, if you like, of the National Data Guardian, and then it can go out to the system. So one of the things that's being worked on at the moment is a simple guide to information sharing, which I know ministers are very concerned goes out to frontline staff because there's been a reluctance to share because of the penalties that the Information Commissioner has rightly placed on in the context of breaches. But that is one of the issues of culture which came up earlier that we found in our review, that people have become very anxious about sharing information because of the fines that have been put in place in the past. There's never been a fine for sharing data inappropriately. So it feels as if the balance is a little bit out of kilter. So it's that sort of issue.
And in terms of the decisions that you're going to be making, is it you on your own? Do you get reports from these different arms? Do you discuss it with your panel?
I think that some of these things are very difficult to make judgments about on your own, however expert you are. It's a very complicated field. So over the last year or two, there are many occasions when I've had to turn to colleagues, be they from general practice, from social care, from public health, and perhaps a group of us discussing an issue to see what it looks like in terms of where we are now and where we need to be. And if you look at the reports that we've written, I think you can see that they're based on a lot of consultation and debate, because this is not an exact science at the moment. Don't know if it'll ever be, but because the system changes. But I think we do our best to try and be up to date and current in supporting best practice, and that shows through, I think, in the way we've worked.
And then you report directly to the Secretary of State.
Exactly.
Okay. And so, for example, a certificate of destruction, is that something that you'd be involved in, destruction of data? Are you the one that needs to be assured that, say, for example, HSCIC said we've deleted this data? Are you the one that needs to be reassured of that?
Yes.
Do you sign off the certificate of destruction?
Not of that.
Right.
Not of that, no. But it's a good question, and perhaps one that we should address as we think about our broader remit, where there are issues that the public has concern about, for instance, destruction of data when it should no longer be retained for its original justifiable purpose, then maybe we need to look at that system. And I think that's the sort of example of what we'll be taking on board as we have more resources to fulfil the role.
Okay. So at the minute, who is doing that? And do they need to report anything to you about
as
whether data's been deleted?
That would be a role within HSCIC, and no, they don't report it to us, although I think there's quite a lot now on their portal about how